All right, are you ready to talk about feeding babies? Because there are so many ways to go about this. I encourage you to learn about the recommendations as well as your options and let your midwife know what your goals are. They will support you to create a feeding plan that you are comfortable with. First off, the official Health Canada recommendation is for all newborns to be exclusively fed human milk for the first 6 months of life. This is because human milk is uniquely designed to meet the metabolic needs of babies, as well as providing important anti-inflammatory and immune-boosting substances, and it's just, in general, great stuff. However, there are times where people cannot chest or breastfeed due to medical conditions, medications they are taking, or because they do not want to use their body this way. And there are times when people are not able to produce milk fast enough to meet the needs of their baby. We live in an area where we have access to safe formula alternatives, so that's also great. I'm going to talk about chest and breastfeeding first, including how it works and the common discomforts, and then I will talk about formula feeding. You may choose to do exclusively one or a hybrid of both. Your choice may be made before you have your baby or may adapt to what happens after they are born. It's all fine. So let's get started. First up, breast and chest feeding. So during pregnancy, the milk-creating tissue in the chest and breast starts to develop and grow. Lactation is the process of continued production of milk. It works on a supply and demand basis. The more often you remove milk from the chest and breast, the more your body will make. This allows your milk supply to increase as your baby grows. They will demand more by feeding more. Colostrum is produced during the first 2 to 3 days postpartum. You make it right away once your baby is born. Sometimes you make it during pregnancy. It is a thick substance that is low in fat and high in carbohydrates, antibodies, and proteins. In the first few days of life, it is all that a healthy and well baby needs. Their stomach is about the size of a chickpea when they are born. Day 1, they are going to work on learning how to feed. Babies in the first 24 hours may be sleepy and not feed for long periods of time. They have never had to actively feed before, so be patient and help them learn. Day 2 babies are often more alert and demanding. This increase in feeding happens as their stomach starts to expand. They will start asking for more frequent feeds to help your body increase the amount of milk you are giving them. Your mature milk comes in between days 2 to 5. If you have had a baby before, it may come in on the earlier side. If this is your first baby, or if you had a cesarean section or had a lot of bleeding during your birth, it may come on the later side. Your hormones are going to go through a big shift when your milk comes in. Often when your milk comes in, your tears come in too. Sometimes you feel like you are on an emotional roller coaster, and this is normal. But if you feel like you are bottoming out, where you only have sad, numb, or increasingly intrusive anxious thoughts, this is not normal. Please talk to your midwife about postpartum depression or anxiety. The main nutrients in mature milk are lactose and other good sugars, milk fat, proteins, and minerals. Milk is bacteriostatic, meaning it helps fight off bacteria and has immune-regulating functions. It aids in digestion and promotes a healthy gut flora for the newborn. Newborn babies need to eat about 8 to 12 times in a day, around the clock. This works out to about every 2 to 3 hours, although if a baby wants to sleep a little bit longer between one set of feeds, like 4 to 5 hours, that's fine, but they should make up for it with a closer set of feeds later on. Feeding cues are how your baby tells you they are hungry. They will do things like licking their lips, bobbing their head towards the nipple while skin to skin on the chest, rooting or nuzzling, or putting their hands to their mouth. A crying baby is a hangry baby, so try to get them before that point. After a vaginal birth, chest and breastfeeding should be attempted within the first hour. Cross cradle is a common position as it keeps the baby skin to skin on the birthing parent's chest. So how you do cross cradle? So I have my baby here. What you do, easiest to start with your dominant hand, you take your hand and I want you to nestle their neck right in between your thumb and your forefinger, right there. Okay, just like this, really nice and tight. And then you wrap your fingers around their jawbone underneath their ears. You can see there and there. I'm holding them very securely. I am not touching the top of their head where they have their soft spots. I'm holding them at the base of their neck and around their jaw. This actually allows me to control their head very well. Then you can see my forearm here is providing support along the baby's back, so that helps keep their body nice and secure. Cross cradle is where you take the hand that's holding your baby and you latch your baby to the opposite breast or chest. So you go across like this. You can use the hand that's on the same side as the side you are feeding on to support your tissue. Cross cradle. When chest and breastfeeding after a cesarean section, football hold may decrease pressure on the birthing parent's incision site. So same hold in the way you're holding the baby, but instead of feeding on the opposite side, you're going to feed on the same side as the arm you were holding with. So you use your forearm to support their back just the same way, and you just tuck them underneath your arm like you're holding a football, and then you latch them on to that same side. This is football hold. You can see from the side as well. All right, so you've figured out the arm positions, but how do you actually get a baby to latch on properly to a nipple? It's all in the way you set them up and how assertive you are with them, okay? So you've got your nice hold here. They're nice and secure. You've got your forearm supporting their body. Your arm is along their jawbone with their neck in that little webbing right there in your hand, okay? So say this is your nipple. You're going to bring them up, okay? You're going to line them up nose to nipple to get your asymmetric latch. You're going to tickle their lips, okay? You're going to get them to open your mouth. And then the goal is to get as much, if not all, of your areola into their mouth. So you have to be quite assertive. Once this baby opens their mouth, you are just going to pop them right on. Okay? You're holding them nice and secure so their head isn't going to jostle anywhere, right? And you're just going to get as much tissue into their mouth as you possibly can, okay? By holding them this way, their airway is open, their little nares are able to breathe, and they can get some good drinking going. If you try to latch them on by holding their head, you see what happens to their airway? You see how that crunches down? Okay, imagine trying to take a glass of water, right? When you take a drink of water, you lift your mouth, right? Try taking a drink of water like this. It is really, really difficult. And if you hold a baby like this and try to latch them on like that, that's essentially what you're doing. So, one more time, line them up nose to nipple, get them to open their mouth, and then when they do, chin in deep, okay? Make that sound in your head if you need to. Then once they are latched, you should see their lips kind of flanged like little fish lips, and then you should see drinking underneath their chin. If the baby is just sucking in their cheeks, that's kind of like they're sucking on a straw, and they're not going to be very effective. I want to see nice, good gulps underneath their chin. Length of feeding varies due to differences in babies and milk flow speed. In general, aim for about 20 minutes of active drinking. This means that the baby is sucking and swallowing, but seriously, this varies. Some babies will not actively drink for 20 minutes straight, so feeding takes longer as you need to work to keep them engaged. Or you have to pause because they need a little break halfway through. Sometimes your baby is full and done after about 10 to 15 minutes. Sometimes you think they are full and done after 10 minutes, but really they are just getting sleepy because the flow has slowed and they don't want to actively work for their food. If you think they are done, try putting them skin to skin with you on your chest over your heart, like this. They will still be able to smell the milk, so if they are still hungry, they'll show you cues like rooting or bobbing or licking their lips or putting their hands in their mouth. Pop them on the other side and keep going. If they are passed out and happy, then you probably have a full baby. If it was a lighter feed, they may want to feed again sooner. Just go with the flow. Learn your baby's cues and behaviors. If your baby is struggling to stay latched on, sometimes increasing the flow speed helps. You can add compressions, where what you do is you grab a big handful of tissue while the baby is feeding. Squeeze and hold. By the way, a little thing about holding your tissue, I don't want to see any of this. That does absolutely nothing to stabilize a nipple or breast or chest tissue. Make a C and really hold your tissue, okay? So a compression is then when you take that hold and you squeeze and hold while the baby is feeding. This increases the internal pressure of the breast or chest tissue and makes the milk come out faster. Compress while the baby is drinking, and then when the baby pauses, take a break. When compressions are not keeping the baby drinking anymore, switch sides. You can also take herbs like fenugreek and blessed thistle to help increase flow speed. On the other hand, if you have an abundant milk supply, sometimes babies will struggle to stay on if the flow is too fast. They may cough and splutter. You can lean back or side lie when feeding is happening to get gravity to help you slow down the milk. Or you can hand express the fastest of the milk off and latch them again when the flow slows down a little bit. Cluster feeding is when your baby wants to feed frequently. Sometimes it seems like you just fed them and they are hungry again. This often occurs when a baby is going through a growth spurt or trying to get your supply to adjust to their needs. Sometimes it happens in the evening when your milk flow is a little bit slower. It's normal. Take a look at the linked article in the description below to tell how your baby is getting enough milk. Moving on to some discomforts that people may experience as they chest or breastfeed their baby. Engorgement is the first one. So this is an inflammatory response that your body has when your mature milk comes in. Symptoms of engorgement include your chest or breast tissue being hard, swollen, hot, and tender. It can sometimes feel like you have bowling balls strapped to your chest. How you help with this is by draining the tissue, either through latching the baby and having them feed, hand expression, or pumping. It will often resolve in 1 to 2 days, but it's not comfortable. Reverse pressure softening is used to soften the areola around the nipple, making it easier to latch the baby on if your tissue is really, really swollen. Cabbage leaves are a really great trick for helping with engorgement. Get a cabbage, just a green cabbage from the grocery store, put it in the fridge, take 2 leaves out, put them on your tissue, leave them on for about 20 minutes, and then throw them away. There is an enzyme in the cabbage that helps break up the swelling. Ice packs and cold compresses can help as well, and then take ibuprofen. It's a good choice as it's also anti-inflammatory, and Tylenol can help if you feel a bit feverish as your milk comes in. Blocked ducts are painful, swollen, firm masses in your breast or chest tissue. You can feel them behind the nipple, you can feel them almost in your armpit, really anywhere. Sometimes a blocked duct can also result in a small blister or bleb at the end of your nipple. Often, although not always, we see these in people who have an abundant milk supply as the baby's just not fully draining those ducts to keep the milk moving. So what can you do about these? Drain your tissue as frequently as possible, working on a really good latch to help the baby get all that milk moving. Angle their chin or their nose towards the blocked duct to help with drainage. If you can't get it all the way out when your baby is feeding, massage it out while the baby is feeding, moving the milk towards your nipple, and you can also do this in a shower or a hot bath. Apply heat to the blocked duct, a heating pad, a hot water bottle, a hot shower, etc., and massage and express it out. You can also take something called lecithin, which is a fat supplement, which can really help move the milk. For blebs, which is again that blister at the end of your nipple, you can do an Epsom salt soak of the nipple, and then with a warm cloth really gently exfoliate the top layer of skin to allow the release of the pressure behind it, and then you massage out that duct as you pump or hand express or feed, what have you. If you have particularly stubborn blocked ducts and blebs, take a full Epsom salt bath and soak the entire breast and chest tissue for about 10 minutes, and then massage out the blocked duct and just honestly express it right into the bath water. Sometimes blocked ducts can be caused by continual pressure in one area of your tissue. For example, a bra that is digging into one spot with the underwire. Avoid tight-fitting clothing and underwires, and it should help reduce that. Mastitis is a bacterial infection of the breast and chest tissue. It can progress from a blocked duct, so that's why it's really important to just get that milk moving if you are experiencing these. Signs and symptoms are, again, that painful blocked duct lump in your breast. However, if you get an infection, it can be red, it can be swollen, and you can get a pretty significant fever and feel pretty unwell. So treatment for mastitis, rest. Like with any infection, resting will help your immune system battle the infection. Use the techniques we just went over to reduce blocked ducts. Page your midwife if your symptoms are still present after 24 hours or if you have a fever above 38.5 degrees. Your midwife may recommend antibiotics at that point. You can continue with your Tylenol and ibuprofen, and you should continue actually feeding from the affected side. The milk may taste a bit salty, so the baby might have to adjust, but it's super important to keep draining that milk, and it's totally safe for the baby to drink. And then, take vitamin C and keep yourself well hydrated. Vasospasm occurs when you have a poor or shallow latch that leads to the baby clamping down on your nipple, and it causes nerve pain. So this can be experienced as a shooting or burning pain during feeds or afterwards. Your nipple might turn white and have an angled lipstick shape when the baby comes off. So if you feel that pain when you are feeding, delatch your baby. How you do this is you have them feeding and then you stick your finger right in their mouth, break the seal, and take them off. Don't just pull them off because they are going to take your nipple with them. They're very strong. So again, little finger, slide it in while they're feeding right into their mouth. You're not going to hurt them. Break the seal and then take them off. And then once you have them off, put dry heat over your nipple, so it can just be like a cloth that you were sitting on during the feed. Put it over your nipple and then vigorously massage your pectoral muscle for about 45 to 60 seconds. If you have the shooting and burning sensation despite these comfort measures and a good latch plus some red, shiny, itchy nipples, and you notice that your baby has white clusters that are stuck to the inside of their mouth or a diaper rash, this might not be nerve pain, it might be thrush, so talk to your midwife. Now let's talk about the dreaded cracked nipples. So when you start chest or breastfeeding, often your nipples feel very raw and tender. This is normal as they start to toughen up for their new job. After feeding, try hand expressing some milk and then painting it on your nipple and then letting it air dry. And then put on your nipple cream before putting your clothes back on to act as a barrier in between the fabric and your very sensitive, tender nipple. Sometimes your nipples may crack and bleed. The biggest thing you can do to prevent this is working on getting a really good latch. If you experience bleeding or cracked nipples, let your midwife know. We can prescribe a medicated cream to help them heal. When your baby latches, they actually pull your nipple back beyond their hard palate to their soft palate. This can pull and pinch for the first few seconds, but then it should not hurt. If your latch hurts from the start of the feed to the end of the feed, then there is something that needs to be fixed. Do not keep feeding through toe curling pain. Delatch the baby like how we talked about by slipping your pinky finger in the side of their mouth, breaking the seal and pulling them off, and try again. Sometimes they will just not open their jaw wide enough. If you are finding that you can get most of the way there, but it still hurts a bit, there's a little trick you can do where you actually hook a finger along their little jaw, right there, along their chin, okay, and then just gently pull their mouth open. If you do this and at the same time bring them really nice and close into your body, sometimes you just get them to open their jaw a little bit and get some more chest and breast tissue into their mouth, and it corrects the latch. It's a little bit easier to do if you have someone helping you, but that's a nice little trick. Sometimes it isn't their jaw at all, but how they are using their tongue. When a baby feeds, they move their tongue in kind of a wave to transfer the milk from you to them. If a baby has a tongue tie, they are not able to do this effectively and they can injure your nipple. Tongue ties are sometimes visible as a tight band of tissue under their tongue, so you might notice that they don't stick their tongue out very far. However, sometimes you cannot see the band of tissue, but their movements are still restricted. Your midwife will assess your baby's mobility and how they are feeding. You might be referred to a pediatrician or a dentist to see if this needs to be clipped. This is usually done either with a laser or with scissors. After the release, lots of babies start feeding better right away. Some babies may need a few days to learn how to use their tongue effectively. The mouth heals so well that for about 30% of babies, some amount of time may actually heal and happen again. If you see a tight band of frenulum, usually what I say to my clients is let's see if it's actually affecting feeding or not. Sometimes you can actually see a frenulum and there's no impact to feeding at all. So it really is the full picture that we are assessing here with tongue ties. A note on nipple shields, they are a tool that have a time and a place. Sometimes if you have very flat or inverted nipples, you may need a nipple shield to stimulate your baby to suck, but not always. Try it without the shield. If your baby is able to latch, often they pull the nipple out as they suck, and they will get better at this as they grow and their mouth gets bigger. However, sometimes I see people using nipple shields as a band-aid for a bad latch. If you need it to get through feeding for a couple of days while your cracks heal and you wait for a tongue tie release, I get that. But if we actually work on fixing the latch instead of relying on the shield as a barrier, then you will prevent cracks, support effective drinking, and increase milk transfer. I'm not saying don't use it if you want to use it. I'm not the one feeding your baby, you are. But they are finicky, so if you don't have to use it, sometimes that's nice. Next, on to pumping milk. Wondering if you should pump or when you are not alone. There are a couple common reasons why people may choose to pump. Number one, they want to increase their supply. Number two, they cannot or do not want to directly chest or breastfeed, but still want to provide their baby with milk. Number three, they are chest or breastfeeding, but they want to give the baby a bottle once in a while when out, or they need to pass on a nighttime feeding to their partner, or they need to be apart from their baby for a while and they want the care provider to be able to give human milk rather than formula. Okay, so reason number one, you are trying to increase your supply. Pumping increases stimulation to your tissue, and as we know, the amount of milk you make or the speed at which you make it is based on supply and demand. Pump after you feed your baby, that way they get first dibs and the fastest part of your flow, and then you condense your feeding activities into one event. Save the extra milk for supplementation. Reason number two, you do not want to feed your baby directly at your chest or breast. You are separated from them, or there's a medical reason why you cannot feed them this way. Pump as often as you would be feeding them, about 8 to 12 times a day, to keep up the supply and demand. And number three, for one reason or another, you just want your baby to be able to take a bottle. This is best done around 3 to 4 weeks of age if you're planning on introducing this method of feeding to an exclusively breast or chest-fed baby. By then, you will have feeding and weight gain well established, but they are still young enough that they will reliably take a bottle as well as a nipple. Pump after feeds when you want to collect the extra milk for this purpose. How often you pump will depend on how much expressed milk you need. If you are happy exclusively chest or breastfeeding your baby and they are gaining weight and things are going well, then you do not need to pump unless you want to. Many babies will never take a bottle, and that's fine. They don't need to unless you need them to. Your partner doesn't have to feed the baby to bond with them. They can have bath time. They can have all the diaper changes in the world to do that. I have linked some milk storage guidelines in the description, so take a look to learn more about pumping and how to properly store your expressed milk. One last note about pumping. Electric pumps, by far the easiest. You can also use manual pumps where you physically squeeze the little receptacle. There is something called a haka, which just kind of attaches to your tissue and then collects the extra milk. That's not exactly extra stimulation, it's just not wasting anything that is coming out anyway. So if you're going to pump for extra stimulation, you need something that is actually working with your breast and chest tissue. Now, let's talk about how to give supplementation to a baby who is chest or breastfeeding. So you can do this in so many ways. For small amounts like colostrum in the first couple of days, you can use a syringe to collect it and give it to the baby on the inside of their cheeks. For more volume, you can use a small medicine cup and they will lap it up like a little kitten. You can use a lactation aid, which is a small feeding tube, by finger feeding or at the nipple while they are latched. These methods are more compatible with chest or breastfeeding than bottle feeding, as they control the flow speed better. Bottle feeding is also an option, and a common one. The worry here is that when you lay a baby down and pour milk into them, so let's get my baby. I've got my baby, lying them down, pouring milk into their face. This baby has very little active participation in their feeding. They don't have to work to drink, so they get to be lazy, and then they don't want to actively work when they have to drink at your tissue. So you can help reduce this by doing something called paced bottle feeding. So that's when you sit the baby up. You can sit them on your lap, okay, and you have the bottle perpendicular to the line of their body, and then you give them a little bit, and then you bring it down, and then you wait. Then you give them a little bit, and then you bring it down, and then you wait. The baby should not finish 2 ounces in 5 minutes. It should take them about 15 to 20 minutes, like how it would be if they were drinking from you. So formula or expressed breast milk does not need to be heated to give it to a baby, by the way, but they will probably like it better. It's like drinking your coffee room temperature or cold instead of nice and warm. Not harmful, just not your favorite. Now, if you choose to or need to give your baby formula, it's preferred that you give them a cow milk-based formula that is iron fortified. Soy, rice, or plant-based formulas should only be used if the baby has a milk allergy. If you are formula feeding, your midwife will help you to calculate how much you need to give your baby at each feed based on their weight and their age, as well as if you are exclusively feeding by formula or if you are combining with human milk. Premixed formulas are considered sterile. If your baby is premature or ill and requiring formula, then this is the safest one to use. For healthy term babies, you can use powder-based formulas as long as you follow the ratios properly in the instructions. Formula does not have the same antibacterial properties that human milk does, so once formula is open or mixed, you cannot reuse it. Regurgitation, also known as spit up, is when your baby brings up a couple of mouthfuls of stomach contents, usually shortly after feeding. Sometimes it can be partly digested, sometimes you feel like everything you worked so hard to feed them just came right back up again. Sometimes, if it has some gas behind it, it can come out with a bit of an oomph and get a surprising amount of air. It's normal. If they are hungry afterwards and showing you cues, just feed them a bit more, and slow down if you are feeding them by bottle. If you have cracked nipples, sometimes you might see a little streak of blood in it. If it's right after the birth, sometimes they bring up a whole bunch of mucus that they swallowed as they were being born. Usually this is caused by an incomplete closure of the lower esophageal sphincter. So kind of in the same way you get heartburn when your esophageal sphincter relaxes during pregnancy, theirs just isn't strong enough to keep all of their contents in their stomach quite yet. So you can reduce spit up by feeding in smaller amounts, gently burping the baby, keeping the baby upright after a feed rather than lying right back down on their backs, and avoiding pressure on the baby's abdomen. Sometimes, when a baby has had a rather enthusiastic spit up, parents worry about projectile vomiting, which can be a sign of a serious intestinal condition. This is rare. Enthusiastic spit up will have an arc to it, and it's not concerning. One time I was at a home visit, and the parent was holding the baby on one side of the couch, and the baby spit up, and it went over top of the parent, over top of me, and then onto the other side of the couch and onto the big sister. It happens. Help your baby alleviate their gas. Projectile vomiting is like someone turns on a high pressure hose. If the infant is projectile vomiting or if there's green bile in their vomit, please page your midwife. How do you help a baby alleviate their gas, you might be asking? So what you can do, and like you wouldn't be doing this on your chest, it's how I can show you. So, but you can, you lie them down and you can do little frog legs where you bend their legs into kind of like their chest or their armpits. This is actually a yoga pose called wind relieving pose, so it does help. You can also bicycle their legs like this, okay? If you're going to burp them, and you don't need to burp a breast or chest fed baby, just do it if you find that they're super gassy. If you are bottle feeding, it's usually a good idea because they take in more air. But what you do is you can support them along their jaw and along your forearm and gently rub their back and help them out. You can do the classic that you see there. Either way, just gentle rubbing and helping them to work out that gas can help. What do you do if you want to stop yourself from lactating and producing milk? So remember, milk production works on a supply and demand basis. So reduce the demand. Wear supportive bras and stimulate your tissue as little as possible. If you are feeling very full, express off only enough milk to feel comfortable. If you feel engorged, use cold compression, cabbage leaves, and oral analgesics like ibuprofen and Tylenol. If you have a blocked duct, it is still important to relieve it so you don't develop mastitis. Drink peppermint and sage teas. These can help reduce milk flow as well. I'm going to finish off this video with the main thing. How do you know if your baby is getting enough? So no matter how you feed your baby, your midwife will be assessing their hydration through their weight gain as well as their pees and poos. For weight, we expect babies to lose a little bit of weight at the start, with peak weight loss around day 3 or 4. After this, they should start gaining at a rate of about half an ounce to 1 ounce a day. As for voids or pees, your baby should have 1 pee on day 1, 2 on day 2, etc. until they are having a good 6 or more nice heavy diapers by the end of the first week. Your midwife will help you to adjust your feeding plan if you need to meet the needs of your baby. Check out the links below in the description for a whole bunch of information on how to feed babies. Like I said at the beginning, there are so many ways to do this. Be honest with your midwife about your experiences and your goals, and they will help to support you to make a plan that works for you and your baby and your family.